Hi, everyone. Welcome to SimiTree's webinar. We're really excited you could join us today. We're going to give everybody just a minute to get into the room and get their audio and everything connected. While we're waiting for that to happen, just a few housekeeping items. If you have any questions during the webinar, please feel free to use the Q&A. We are going to try and leave some time at the end to get to questions. I will post the handout for the slide deck into the chat. It may get posted a couple of times because the chat doesn't account for people entering the room. So we'll post it there as people enter so that everybody has access to it. With that, I'm Missy Gilliland, the Director of Learning and Development. We're really glad you could join us today to talk through some revenue cycle issues and how you can best manage through that. I'm going to turn it over to two of the best experts in the business, Ashley and Nick, to introduce themselves and get us started. So Nick, why don't you introduce yourself?
Thanks, Missy. Hello, everyone. Appreciate you all taking the time to join us on our webinar today. As Missy said, my name is Nick Corbi. I'm a senior consultant with SimiTree. And regarding a lot of the concepts that we're going to be talking about today, a lot of my focus falls within both home health and hospice, and really excited to meeting everyone a little bit further. And with that, I will pass it over to Ashley, who will kick off our webinar today.
Sure. Thank you, Missy. Thank you, Nick. Welcome, everyone. Thank you for joining us today as we take you through managing today's revenue cycle issues. My name is Ashley Michael. I'm a senior manager here with SimiTree. Been working in home health hospice for 13 years. So a lot of my expertise going into these areas. So look forward to working with you. Feel free as we go along, enter your questions into the chat. We will leave time at the end of the webinar to address those as we can. So right off, we'll just start with the objectives for today. So we're going to review the Medicare Advantage landscape for home health and both hospice, what that expansion looks like, and also to let you agencies know how to manage those MA plans within your current agency's home health hospice specific. Also, looking into how we can help you build relationships with payers by building that value proposition through data analysis and understand where your home health and your hospice agency can provide value to those payers by using the data of the patient care, the patient quality scores that you're already taking on with your agencies to be able to prove to those payers what you can do for their Medicare Advantage patients coming through to home health and hospice. Understanding the VBID model for hospice, and then moving into managing your overall home health and hospice AR. All right, so for home health and a hospice agency, it is extremely important to understand that Medicare Advantage landscape and growth. And so we're going to look at that within the next few slides. Just for growth in particular, you can see on this chart, in 2022, more than 28 million beneficiaries enrolled, that being nearly half of 48% of that eligible population. That was an increase at 2.2 million increase, 8% over 2021 to 2022. Understanding that that MA population, it comprises of 26% of those home health agencies' revenue in general, and then 28% of those visits performed. So as you can see on this chart, for the year of 2023, looking to increase to 52 participating MA plans, that totaling 9.3 million enrollees. So with just those numbers in general, understanding that for both home health hospice, we have to be prepared. We have to proactively look into what that Medicare Advantage plan is going to do for our home health hospice agencies, and how are we going to operate against it? How are we going to operate to make sure that we know how to process through Medicare Advantage plans, contracts, negotiations, authorizations, and that kind of thing. And we'll get to those in further slides. And then just specific for VBID, 6 million of those enrollees estimated to receive additional model benefits and or rewards and incentives as part of that test in 2023. Okay, so what does this mean for your home health landscape? Increasing portion of your payer mix. Understanding that payer mix is huge in both home health, particular hospice. understanding what that means when our payer mix changes from a more traditional Medicare patient load to a more Medicare Advantage patient load. Understanding that authorization requirements are going to be huge for those Medicare Advantage plans. Super important for agencies to research and to know what those authorization requirements are, what to be sent in for that. Do we have retro periods? Do we not? What documentation is needed? And all that will come into further slides as well. So as that portion of our payer mix increases, understanding that higher volume of claim denials, whether that is for inaccurate information gathered at verification, whether that is for authorization not received timely, understanding that when we increase our volume of MA payers, we also could potentially increase the volume of claim denials for those various reasons. And then often lower reimbursements. We all know that whenever we want to negotiate to contract with those MA plans, those negotiations are tedious. And we often have to fight for the rate that we want our home health or hospice agency to receive. So those rates could be lower. We could get reimbursed for lower than our typical Medicare patients that come through for both home health and hospice. Also, inconsistent adoption of new traditional Medicare regulations. Understanding that some plans, some MA plans will follow that PDGM driven model to where we get paid those PDGM rates. Some MA plans will not. Some, the notice of admissions, some specific to home health. Some of your agency or some of the payers will follow that process where you have to submit the NOA timely in order to get paid properly. And then some are not going to follow that process. So understanding and researching those inconsistencies that are going to come around being contracted and seeing patients that have those MA plans within your home health and hospice agencies. Also, understand that telehealth is expanding and understanding what those billing requirements is for telehealth. What codes do we bill for those? How are the services charged for those? So understanding that that is huge and has been upcoming for a while, but is going to take more into effect whenever these MA plans kick in. And we're going to have to, as home health agencies, as hospice agencies, learn what those billing requirements are. And then lastly, the future of value-based purchasing, understanding what that is and being able to tie that into your home health landscape and also into the landscape of other services that you provide, whether it be home health or telehealth within your home health landscape as a whole. All right. So how do agencies manage to that increase of MA plans, to that increase of Medicare Advantage plans that are coming? Starting off, number one, learn those MA plans, common requirements and challenges. Some of those challenges being lack of clarity when checking eligibility. We all know that that eligibility check could be tedious, could be difficult to read whenever we pull the eligibility report. So making sure we have someone in place, someone educated enough to be able to pull that data, to look at it, and to be able to understand what that means for the agency and for the patient. So that lack of clarity whenever pulling that could potentially be a challenge whenever we move into seeing those MA patients. Also, the need for authorization. Understanding the need for authorization, whether that be initial or ongoing, is going to be huge for the Medicare Advantage population, for both home health and hospice. Understanding what that authorization process looks like. Do they give us timely filing? Do they give us a retro period? Are they a no retro payer where if the start of care is done today, the authorization has to be submitted today or we won't get paid for that visit? So understanding that and that falls into the next point, research those plans and see what those challenges are and come prepared with processes, ideas, standardization of those processes on how to go through with how you're going to deal with those patients that come on board. Timely filing guidelines. Do they give us specific timely filing guidelines if they don't already follow the Medicare timely filing guideline? Understanding that there's longer claim processing time. There's more that goes into a Medicare Advantage plan, whether it be authorization or when they request medical records to be sent in order to pay for those visits or even in order to give us authorization. So understanding that a challenge or a barrier could be a longer claim processing time. Also, variances in billing codes. So very important for us to research those plans and understand what particular codes they want us to be billing under, what particular HCPCS codes that we need to submit for authorization. So super important for that process to understand what the requirements are, and they could or could not potentially be challenges for your agency. And then lastly, just for learning common requirements challenges, if for whatever reason you guys have to go through an appeals process, that appeals process for Medicare Advantage plans could be more tedious than any other plan, most requiring some sort of documentation to be sent, medical records to be sent. So just making sure as an agency you're aware of those things and knowing how you're going to act and process through those. All right, so research plans. As an agency, you want to research those MA plans to understand what benefits, what services are going to be covered under those plans for your actual patients. Again, huge authorizations. What authorization requirements are going to come through with those plans? What is that process going to look like? What does that MA plan tell you the process is going to look like? And also making sure as an agency, you're putting in a plan to follow through with that process in order to get authorization, in order to get that claim sent out the door with authorization tied to it. Are medical records needed? Are medical records review needed? What kind of collaboration does that MA plan want with you as an agency? Do they consistently want you to send medical records for them to look at? Do they consistently want you 2 weeks at a time to request authorization with medical records to process through, either to approve visits or deny visits? What kind of collaboration as a home health or hospice agency is needed to be able to work with that MA plan? And really, is the agency willing to do that? Are they willing to send medical records when they're asked, or are they not? So understanding and researching what those plans want. Also, timely filing, huge. Very important for your agency to research those plans and what that timely filing looks like. How quickly does the plan pay? We always want to know when we get that claim out the door, either it's a clean claim or it's come back and we've updated it and we send it back out. How much time are we expecting before we get money in the door for our agency? And all that comes with researching those plans and being able to understand what they are and what information they can give you back. Lastly, for that, researching the plans to understand what the payment options are. Does the plan pay per visit? Does the plan pay per hour? Do they pay episodically? So that where those all can be different, super important for agencies to research plans to find that information out. So that moves down into negotiation. Learning to negotiate, so come prepared and be prepared. Understanding that all of these bullet points right here on this slide, super important in that negotiation process. Understanding what goes into the plan, understanding challenges, understanding what contracts look like, all of that data, super important when you sit at the table to do that negotiation, to have those conversations about that and to be prepared with that. And we get to that in a bullet point down below. Oh, sorry, Miss. All right, so know your contracts and what they mean for your agency. Know what your contracts are once you get those. And also, do you have contacts? Does your agency have a contact with an MA plan that they can pick up the phone and call? They can email to ask questions so they better understand what that plan is. Part of that research plan, do you make sure your agency understands the contract, what it means? Also super important, if for whatever reason you have a contact at that MA plan or MA payer, to reach out to them to help guide you through that process and to give you answers that you may not get any other way. All right. Understand the payer and what they want. Again, kind of hit on this and other bullet points on this slide, but what benefits do they cover? Again, authorization process. I love the authorization process, so you'll hear me harp on that a lot. What does that authorization process look like for the MA plans? What guidelines? What is required? Do they give us a 14-day retro period where we can send all that documentation out in order to get authorization? So understanding what those guidelines are, and then also specific to timely filing and then payment options that we've already discussed. All right, so that bullet point, drive conversations using data analytics from the agency, is huge whenever you're going to negotiate a contract with the MA payer. Understanding that just for home health specific, that MA plan is looking for quality outcomes. They're looking for how has agency so-and-so helped patients thus far. They're looking at quality outcomes. They're looking at rehospitalization rates, because we all know that home health is intended to keep our patients out of the hospital. So they look at those rates. They look at the timeliness of care. Are we seeing as an agency that patient within 24 to 48 hours? Understanding that that's a guideline and that goes into a timeliness of care score, that if that score is quote unquote good, we can take that data to the MA plan and present it to say, hey, we're taking care of our patients. Our quality scores are high. Our rehospitalization rates are low. Our timeliness of care, we're getting out there within 24 hours, even down to our patient satisfaction scores. Understanding what goes into those patient satisfaction scores and being able to talk to that. If for whatever reason, when our patients finish service, they give us a bad score at that point, being able to talk to that, but also being able to bring to the table positive patient satisfaction scores. Also, some other things that MA plan may be looking for in home health specific: medication reconciliations, how often that patient is going to the ER, because we also as home health want to keep the patient out of the ER as possible. So all those things going into what that MA plan is looking for from a home health agency when they're coming to the table to try to get a contract or try to negotiate that contract. Hospice specific, what that MA plan is looking at for hospice agencies, sort of along the same lines of home health, just some different verbiage. They look at the care compare at those scores on there, claim-based measures that are out there for everyone to see. Also rehospitalizations, big for both home health and hospice. And then also the levels of care for the patients that come through. All right, so last two bullet points: know your costs and margins. Understanding that whenever we contract with MA plans, it's going to bring more cost to our agency, going to bring more staff to our agency, and along with staffing comes cost. So understand to have a plan around all of that. Understanding that we could potentially lose reimbursement from denials of the reasons that we've already talked about. Authorization, maybe eligibility was done incorrectly. Maybe the patient has a copay or coinsurance or deductible, and we are expecting that patient to then turn around and pay the agency those financial responsibilities that they're owed to us, and maybe they don't. So that could be a lack or a loss of reimbursement in that area. Also, collection costs, card processing fees, administrative overhead, all costs that go into contracting, negotiating to contract with those MA plans, and what that looks like for the home health and hospice agency. And then specific for staffing, we all understand that with each new patient that comes aboard for home health and hospice with an MA plan, comes additional work around verification, around authorization, and around billing. So we have to be able to do a staff analysis on how many patients do we have that require authorization. Does this mean we need more verification folks on team? Does this mean that we need to hire more authorization folks? Does this mean that we need to hire more folks in our billing department to get those claims processed, to follow up on TPEs and to get them sent out again? So understanding that whenever your agency thinks about expanding into MA plans, there's a lot that's going to go into that. Specific, just this last bullet point on staffing costs, understanding that the more plans we have, the more patients we see with those plans, their staffing is going to increase in those verification, authorization, and billing departments. All right, so in order to set yourself apart from other agencies, both home health, hospice, you must build a value proposition through data to show that your agency is a value to those payers, both home health, hospice. So understanding that everything we talked about before, coming to the table with quality outcomes, coming to the table with good patient satisfaction scores, with a good rehospitalization rate, understanding what that payer is going to require and what your process is to, I want to say, defeat the barriers to taking on MA patients. All of that together is going to help you as an agency, home health, hospice, both, build a value proposition for your home health agency, for your hospice agency, to be able to tell a story to them to say, the last 15 patients that we have gotten better specific to home health. The quality outcome scores have gotten better. The patient never went back into the hospital. And that is going to help build that relationship with the payer for them to say, okay, that's fine. Let's move on. Let's sign this contract with the actual payer. So just building that value proposition as you go through. All right. So as we take a look at hospice specific, understanding that you have to take into account VBID. The goal of VBID, value-based insurance design, is for hospice care to improve their quality of care and outcomes for patients receiving hospice services while also containing and controlling costs. So you can see that this demonstration was initiated in 2021, will go through 2024, and also will enter the third phase of the model into 2030. So with all that being said, we see that this VBID process is ever changing. Now I'll throw it over to Nick to talk more about that process.
Thank you, Ashley. Yes, just to dive on that a little bit deeper, it is important to note that with all of the materials and information listed here on VBID that you'll be able to review on your own time after the webinar, it's important to note that currently as philosophies and guidelines, for example, VBID, are continuing to change, evolve with their set cadence and plans, it's important to note that as we are talking about this right now, there in fact are specific plans that are continuing to either they're weighing the option of whether they're going to stay within VBID or pulling out of VBID. So back to the points that Ashley was bringing up earlier, it's important that payer communication in regards to the contract negotiations and just overall communication with the payers as you continue to take on specific commercial or MA plans moving forward. The communication with the payers is important to understand where they stand specifically within hospice with the future of VBID moving forward as part of your payer mix. And then on to the next slide, we should be able to dive a little bit deeper into the concepts regarding managing home health and hospice AR in relation to the multitude of concepts and the challenges that Ashley was diving into a little bit deeper prior regarding Medicare Advantage plans and so forth. Specifically, the concepts that we're going to be talking about are labeled as process improvements, but ultimately more so just concepts of practice and how we're addressing all the various different aspects. Now, it's important to note that with all the information that we'll be talking about for the remainder of the presentation, they're titled under unbilled AR because we see and highlight the multitude of focus on unbilled AR, specifically within AR management in relation to Medicare Advantage plans. For a lot of the reasons that Ashley was talking about earlier, it's important to note that a high number of unbilled accounts obviously has a negative impact on cash flow. So it's important to understand and monitor those payer timely filing limits and all the various different requirements from a billing standpoint that could be required with the varying Medicare Advantage plans that you could find within a given payer mix of a given agency. And as part of the AR management aspect of this, it's important that all AR should be addressed, both unbilled and billed AR, for total AR analysis to understand and evaluate the true health of the accounts receivable within a given agency. It's important to not sector these off when you're taking a look at total AR, but only when you're addressing billed AR and the aging of billed AR on a separate level, and unbilled AR and how it combines towards the overall health and current state of affairs. I'm diving a little bit deeper into unbilled AR, understanding that it should be tracked and measured regularly. And as part of your regular AR and KPI reporting, unbilled AR should be part of that routine cadence for a lot of the reasons that we've already discussed and some reasons that we'll be getting into a little bit further. And then it is important to also clearly delineate whose responsibility for specific issues that are preventing billing, whether it's timely filing, whether it's orders management, whether it's authorization workflows, understanding how all of those teams and the interdepartmental cooperation is important to making sure that claims are being billed out on a timely manner to keep cash flow on a consistent basis with Medicare Advantage plans, and really just all of the different payer categories that could be addressed in their totality. And then the final bullet that we have on this slide here is just regarding unbilled AR as a best practice metric of what to monitor. Again, for the goals of high-performing agencies, unbilled AR should be less than 10% of average monthly revenue for AR that is greater than 30 days. And then to expand on the unbilled AR and AR management as a whole, in this next slide, just understanding a little bit deeper what the tracking and trending of unbilled AR reasons are. Again, it's important to note that the same concepts that are used to track billed AR and denials management, those same concepts in terms of how you analyze specific data, aging buckets, trend analysis, that can be applied to tracking unbilled AR reasons as well. Specifically differentiating and identifying between home health and hospice, what MA plans are causing greater unbilled percentages within home health and hospice separately, and how is that impacting your total unbilled percentage as a whole. And then also specifically for hospice, tracking sequential billing and seeing if there's any specific reasons applied to the concepts that Ashley was discussing above that are related to increased amounts of sequential billing holds that is resulting to less hospice AR being billed out the door. And then to dive into another concept as part of the pre-bill audit stage is outstanding orders and CTIs. Again, the goal of high-performing agencies should be less than 10% of outstanding orders aged over 30 days. And then how are you tracking these orders? What are your sources, whether they're portals, phone calls, faxes incoming? And then ultimately, how are the physicians' offices being communicated with on outstanding orders and medical records? And then ultimately evaluating what current escalation process is for more aged out bill holds related to orders tracking, because it is important to evaluate current process and see where any potential changes would need to be made to ultimately continue to automate that process as best as possible and ease days to billing. And then finally on this slide, we have documentation and visits. Again, what is the goal of the high-performing agencies? It should be to document within 24 hours of the visit. Again, this is important to highlight here because with the Medicare Advantage plans, as part of that greater concept of stricter restrictions, and then ultimately a more condensed timely filing workflow, it's important to take a look at the issues that are highlighted and concepts on this slide and to not let them snowball and really hone in and sharpen the processes across the board, not only for Medicare Advantage, but also for traditional Medicare and then commercial plans as well, so that you can evaluate all of your payer categories in relation to these concepts in their totality. And then the next slide we have here is the concept of reporting KPIs. So when taking a look at all the information that we've discussed here related to the webinar today, how do we track this in relation to AR management and AR tracking? So with the list that I have mentioned here, it's important to note these are just some of the best practice KPIs that could be tracked to help build on and expand on the concepts that Ashley was talking about further a little bit ago, and specifically with days to NOA and NOE. So what this KPI stands for is the number of days it takes for a hospice agency to receive the notice of admission or the notice of election after a patient's admission. We typically like to see this within 2 days after the patient's admission. But again, it's important to understand what that number is and how that number is currently being tracked. And if days to NOA and days to NOE isn't something that is being tracked already, it is a KPI that needs to be implemented into your regular KPI reporting cadence. Days to bill being the number of days it takes for agencies to generate a bill for services provided to that patient. Again, talking about that pre-bill audit process and what all of the various different workflows are within that system. Where is an agency strongest versus where are areas of opportunity for an agency to ultimately rectify some potential issues that could be increasing that days to bill KPI metric. And then we've talked about unbilled AR in its totality and all of the effects, but then ultimately looking at total AR and understanding AR over 90 days and how that relates to Medicare Advantage plans in relation to your total payer categories. Because again, with a lot of the challenges that have been highlighted regarding Medicare Advantage plans, delayed billing, multiple increases in denials, again, taking a look at that aged AR percentage over 90 days, what percentage of that is Medicare Advantage plans in relation to total AR, and how can that be combated as part of denials management and so forth from there. And then other mentions are daily days to sales outstanding, DSO, then your bad debt ratio, cash posting. And what isn't mentioned here, but another important concept as well, is collections to revenue. So ultimately, what is the revenue being generated by Medicare Advantage plans? And then what is the percentage of collections in relation to that in relation to that revenue, for all the reasons that were mentioned above, especially regarding margins and so forth from there. And then on the next slide, what we have here is a list that can be reviewed further. And if there are any questions later on, I'm again happy to answer any questions. We have some specific benchmark practices and percentages for a multitude of the KPIs that were listed on the slide prior that we feel are important to highlight here, so that ultimately when evaluating if certain KPIs are part of your current reporting cadence, what are the metrics that are being highlighted as part of these KPIs, and where are the metrics that are being found within a specific agency in relation to industry best practice. And then on the next slide, to ultimately bring this concept to a close, in regards to everything that Ashley and I had spoken on today, is ultimately how can an agency optimize its potential with SimiTree? Again, when taking a look at all the concepts related to Medicare Advantage, for both hospice and home health, and the potential adverse effects that it can have on an agency if not prepared correctly, ultimately taking a look at what's listed below is how to leverage SimiTree's expertise and cutting edge data analysis to elevate your management of Medicare Advantage plans. And then moving forward is just to explore how effective cash management can revolutionize your agency's financial health for the multitude of reasons that we've listed in the contents of this presentation today. And then ultimately, what we've recently just mentioned is working to craft powerful KPIs and dynamic dashboards to really automate, from a technological standpoint, the understanding of the effects that Medicare Advantage plans can have on the financial health of your agency, for both financial and clinical operations in their totality. And again, as mentioned, to go to our final slide here, if there is any further questions that you do have, you can happily explore further at SimiTree's website, SimiTreeHC.com. And you also have both my email and Ashley's. And again, if any further questions, feel absolutely free to reach out to us after the fact, and we'll take any questions that are coming in, and we'll make sure to answer them at any point moving forward.
Excellent. Thank you, Nick. Thanks, Ashley. This is great information. I really appreciate everybody joining us today. As Nick said, if you have any questions, feel free to reach out. This presentation will be emailed out, a recording and a copy of the handout, plus any questions that were asked will be included as well. We're really excited you could have joined us today. As always, reach out to SimiTreeHC.com, and we're glad you could join us today. Nick and Ashley, thank you so much for sharing your expertise.
Thank you so much. Thank you guys for attending.
Thank you, everybody. Thank you, Missy.
Yeah.
Thank you.
Take care.
Take care.